So welcome. Thank you, Eunice, for joining us. We're super excited to have you today. So for everyone who's joined, if you weren't already aware, this is Eunice Gribbin. She has had over 40 years of experience, and she's a clinical nurse who also holds a Master's of Health Laws, and is currently doing a PhD, as we just discovered, somehow juggling that with the rest of the work she's got going on. And Eunice, I would believe, has been working in the medico-legal space for over 15 years. So massive wealth of experience there. And today she will be presenting on the value of expert nursing opinions. So yeah, look, that's a bit of an intro. I'm going to hand over to Eunice. I'll make you the host if you give me one moment. Okay. So Eunice, I've just made you the host. You're welcome to share your screen. I will mute myself, and anyone else who might have their microphones on, I'll get you to mute your microphone. Yeah, you can take it away after that.
Okay. Let's go back a page. Well, thank you for the invitation. It's great to be here with you all today. Just to talk about the value of expert nursing opinions. And they've certainly something that has become much, much more valuable over the last 15 years from when I first started embarking on this area. Something I never thought I'd be doing, but here I am, and it's growing. Initially, I started working for the Healthcare Complaints Commission, which was my first experience of doing. And after completing the Master of Health Law, I decided to go out on my own. So I just wanted to give you a bit of an overview of what kinds of things nurses can find, can pick up, can help you with your reports. So if you just look at those two pictures there, you can see back in the day, although I was never a nurse on a bicycle, that's obviously taken from Call the Midwife. But the era of nursing in the sort of 50s, 60s, 70s was very, very different to what you can see on the right. Unfortunately, that's more of our picture today for the last few years since COVID first began. Let's hope we eventually return to something in between those two, you know, some sort of normality where we have much more patient care, which would be lovely in person, where the patients can actually see us and touch us. So how do you choose an expert nurse? Well, if you look at those things, you have to be a registered nurse. You have to be registered with APRA, which is the registration body for all health professionals. You need to have a postgrad law degree just to have a basic understanding. Not for a minute do I think that I could take over the job of the lawyers. Absolutely not. It's completely not my area. But it does give us a background and an understanding, particularly the health law degree, what it is you need to help your case, to support your case. You would want to see that nurses have continued with their education beyond their base degree, because the base degree is simply that. It gives you a base and then you grow from that. And it's something that I've continued throughout my entire life. You also need to understand, and this comes in the initial introduction with a nurse expert, it's just understanding that they do have the appropriate skills that you need for your case. Because there's no point, for example, I do not have mental health experience. Yes, I've looked after students in mental health facilities, both inpatient and community, and a lot of NGOs, but that doesn't make me a specialist in mental health. And I would tell you that if that appeared to be what the case was you were looking at. So let's have a look at how we can assist your case. For a start, nursing and doctors' roles are very different. The doctors diagnose a condition, they maybe send the patient to hospital for some nursing care, or they come in for procedures, operations, what have you. But the doctors are in and out. They come in, go over how the patient's feeling generally, do a little, you know, examination themselves, look at the notes, talk to the nurses if they do. A lot of the time these days they don't, unfortunately. And then they give instructions by writing in the progress notes and continue to review the patients. But the bulk of is provided 24 hours a day by the nurses. And it's up to the nurses to carry out their orders and contact the treating team if anything is concerning them. Systems in place in the hospitals now to support nursing staff when things go wrong. Sadly, they're not always utilised. So some of the failures, an overall failure would be to observe, monitor, recognise deterioration and know when to escalate. One of the biggest things is knowing at what point do you escalate. I've seen some shocking cases where patients' observations have been in their boots and continued to deteriorate post-op, for example, and yet nobody recognised. They conducted the observations, they recorded them, but they didn't do anything about them. So what kind of cases do we get involved with? These are the kinds of cases I've been involved in. A lot of critical care, because my background is perioperative nursing, both in adults and paediatrics, which covered anaesthetic and post-op care. I've also worked in ICU, emergency. I'm not a midwife, but I have just completed a postgrad qualification in midwifery, maternal critical care, which is both acute and chronic. And I've also been heavily involved in maternity throughout my training and my years of experience. I guess the link between the operating theatre, where we perform procedures, gynecological procedures, and things go wrong during the delivery and patients come to theatre to have the delivery enhanced by instrumental means. So there's been a lot of crossover between maternity and peri-op work for me, and I had quite an interest in that area. A lot of cases regarding sepsis, where again sepsis wasn't recognised, and it has led to amputations and death in some cases. We get a lot of extravasation of iron, chemotherapy, IV fluids, etc., which cause no end of trauma to the patients, usually their arm. There's quite a few traumatic procedures, catheterization. I recently did a case with an NG tube, which was catastrophic, put in incorrectly. Catheterizations, it's usually the catheter is either withdrawn before the balloon is blown up. There's a balloon that keeps it anchored within the bladder, but unfortunately, in some cases, the catheter is withdrawn without the balloon being deflated, which causes no end of trauma to the urethra. Cauda equina, compartment syndrome, they're all sort of post-op things that occur that go unrecognised unless there's really careful monitoring and observation. Lots of falls, some nurse injuries, and anything to do with standards of care, really. So just looking at some of the cases, for example, HIE, the hypoxic ischemic encephalopathy, which is tragic for the newborn. Something's gone wrong where there's been an interruption to the flow of blood to the brain, and the result is brain damage or even death, which is really tragic. Unfortunately, the two outcomes, as you can see there, neither of them were palatable at all, and certainly not not what any nurse or midwife comes into work expecting to do, but sadly things do go wrong. Very sad cases of neonatal suffocation where the mother and these have been, one was in hospital, another was at home where the mother has been feeding her baby, fallen asleep, and unfortunately the baby's suffocated during that period of time. The one in hospital, the baby did survive, but was severely brain injured as a result. The other one at home died, wasn't recognised until the mother woke up some hours later and the baby was lying dead next to her. It was a terribly tragic case. So many things. I'm sure you're all very familiar with the term foreseeable and preventable, and in most cases they are. One case that sticks out in my mind is a 24-year-old lady who came in because of a motor vehicle accident. The only injury she had was a fractured pelvis and the head of her femur. Nothing else was a problem. She didn't have anything above her pelvis, so her chest wasn't injured, and she certainly had no head injury. And she was only 24 years old, very young and healthy. But this is where we have the dangers of inexperienced staff and also the dangers of casual or temporary or agency staff. Not always, but in this case it certainly was. As a nurse, we go through, when you ask me to look at a case, I look at every aspect of the case. So I prefer you to send me all of the notes and I sift through and work out what's important to me. So you bring together the observation charts, the progress notes, the pathology reports, anything I can find, and I tie them all together to see, do they marry up the care plans? What might be in one document may not be reflected in another, and sometimes you can pick things up that way. So this particular young girl who came in with a fractured pelvis, her family kept saying for many, many days that something wasn't right. She was slurring her words a little bit. She didn't sound like herself, but there was nothing really obvious. And friends who came in to visit her said, wow, something's not right. And the key thing there is the people who knew her best recognised something was amiss. But of course, to the nursing staff, they didn't know her beforehand. So to them, that's all they knew. The family did keep repeatedly going to the nurse's station saying something was wrong. So did her friends. The kinds of responses they got were, oh, she seems fine to me. I will keep an eye on her. I will get the doctor to come and have a look at her. One even said, well, she's not my patient, which is just absolutely abhorrent. What actually happened in this case was, as I said, between the different notes that we look at, her sodium level had been taken quite soon. It's just a routine bloods when she came in. And that sodium level was actually quite low, not critically low, on the day that she arrived. By day 3, the pathology had actually called because she'd had another blood test done and her sodium had dropped really quite critically. Now, pathology don't ring the ward with a result unless there's a real problem. Unfortunately, that RN, it was the end of her shift. She was an agency nurse. She wrote it in the progress notes, what her sodium level was. Now, whether the oncoming staff didn't recognise the number that she had quoted, or whether they just didn't read the notes before of what had happened before she came on duty, we don't know. But what we do know is, although the RN who was the agency nurse noted it in the progress notes, they didn't hand it over to the oncoming nurse. They failed to report. What they ought to have done was immediately called the treating team for an urgent review, because her sodium by that stage was so low that it was causing her deterioration. By another blood test was done. Again, nobody had looked back through the notes, which is a nursing duty. When you come on, you're supposed to look back and see what's happened since you were last on, or if you don't know that patient. The registrar came and did another blood. This time, he actually read the report when it came through and realised how seriously ill she was. That's when she was sent to ICU. And unfortunately, with sodium, you have to correct it very slowly, because if you correct it too quickly, you have the opposite effect. She ended up in, as you can see there, locked in state for almost 4 years, and she died aged just 28 years old. Now, that was absolutely preventable. Extravasation, this is one example of extravasation of chemotherapy. This was through what we call a portacath, which, as you can see by that first picture, is just a little dome that sits underneath the skin. And when people are on chemotherapy, it saves them having needles every time to administer their chemotherapy. They just have this port implanted, a minor operation, and then the dome, which is underneath the skin, it pokes out, so you can see a lump underneath the skin. But the top of the dome is almost like a skin, like a drum. So when the nurses can inject the chemotherapy into the portacath, and it goes directly into the right side of the heart. What happened in this case was the needle that was chosen to access the port was not long enough. So it actually didn't reach the portacath. It actually just dispersed the chemotherapy directly into her skin. What ended up, this lady had had a mastectomy on one side and had the portacath on the other side, but because of the severe problems caused by the chemotherapy extravasating directly into her skin, she ended up losing the other breast as well. That's just an example of extravasation of iron. As you can see, the staining there. It's most likely that this particular iron was injected through the cubital fossa, which is where your elbow is, on the inside of your elbow. It's something that is a simple procedure if done correctly, but it needs very, very close observation and monitoring, because even though it can only take 15 to 30 minutes for it to go through, if it leaks out from the vein, the iron will stain the skin. And that's the only reason the skin stains, is if the iron has extravasated out of the vein. And unfortunately, this staining is usually permanent. They can have laser, which might make a slight improvement, but it's unlikely. I had one young girl who wore long sleeves all the time because people thought, they were worried about her. They thought she was actually being abused by her partner because she had these, what looked like bruising all over her. Post-op care, we've talked a little bit about that. Monitoring and recording observations, knowing when to recognise, how to recognise deterioration is so important, and calling for review. There are escalation policies in all hospitals. You generally, when you're on a ward, you escalate to the team leader. That's someone who's in charge at that time of the ward. You also escalate, depending on the time of day. If it's after hours, you would be escalating to the night manager. If it's a private hospital or an aged care facility, it would be to the care manager. But the important thing is to escalate care. and follow the policies that are written in each hospital. One of the quite well-known cases is Stefansic and Brown, which I provided a report on and then was involved in a conclave, and then the Supreme Court giving evidence against this terrible case where the woman had a hysterectomy. Post-op, she had obvious signs of deterioration which were never addressed. She was vomiting, and at the end, towards the end, I think the last nursing note I read had that she was vomiting fecal fluid. Otherwise, she was well. I'm sorry, but those two things completely contradict each other. Vomiting fecal fluid means you're vomiting your feces, which is absolutely dreadful. And it immediately indicates there's a bowel obstruction, and certainly there was in this case, which was never picked up, and the lady died. In the emergency department, a lot of the issues there are failing to triage correctly. When patients are triaged, they might be discharged without seeing a doctor because their condition seems like it wasn't that important. We've seen cases of, as I've got written there, the post-op purulent wounds discharged, which became severe sepsis, and the lady had amputations of all 4 limbs. Hands and feet below knee amputations. So extremely difficult to carry on after that. There's been a couple of cases of ruptured appendix which have been missed. Quite a few cases of myocardial infarction or heart attack where patients have come in. One particular man came in saying it only hurt when he was digging in the garden and he thinks he's pulled a muscle. And instead of investigating to make sure that that was the cause, the man was just given some denka rub and told to go home. Unfortunately, he had a massive heart attack, which was actually going on at the time, which was unrecognised, and he died. There's a couple of coroners cases that I've been involved in. There's another one on the boil at the moment. I actually quite enjoy inquests because it's an opportunity to really look at every aspect of the case in detail with hopefully plenty of time, and you can analyse what's actually gone wrong and hear from the other clinicians as to their input as well. Sadly, I've also had a couple of criminal cases. The one, which I'm sure you all know, the young nurse who set fire to an aged care facility. Clearly, he was not terribly bright in the way he was thinking, because his intention to cover his tracks of stealing drugs was to lock the particular ward with residents inside, set it on fire. His only intention was to get rid of the drug book, which would have clearly identified that the drug count was out, and they would have quickly nailed down, which is what they did do, that he was the one on duty every time there was a discrepancy. But unfortunately, it went terribly, terribly wrong, as we know from the history, and several people died. Just an awful, awful tragedy. Then there was another nurse who deliberately injected insulin into non-diabetic residents. This was in an aged care facility up in Newcastle. Some of you may know the case. The nurse at the time applied for a job, was given the job, and they only did night duty. And this particular care facility, they were the only registered nurse on duty, so they were the only one who had access to the keys. The systems in place for storage of insulin were substandard, which I was able to discover, fortunately, from photos the police had taken. And he, for some reason or other, had taken a dislike to these 3 residents and injected them with insulin on the same night. And they all ended up in hospital because they became unconscious. Luckily, the doctor who was on in emergency recognised these 3 people had very low blood sugars, but they weren't diabetic. What was going on? The risk with insulin, of course, is it's not detectable. So it was thankfully because of that doctor in emergency, he was able to recognise what might have been going on and reported it to police. A recent claim I did for the in regard to an NDIS participant, I'm sure you will have, some of you will have heard about this poor young girl. She was in a swimming lesson from her school. It was actually a school excursion to the pool. I think she was about 12 years old at the time. A swimming instructor from the pool instructed her to dive in. She dived into the pool, hit her head. It was being reports from the specialists. There was one particular specialist who was able to analyse what the pool would have needed to be for her to successfully dive in.
So
and clearly,
Eunice, you just cut out a little bit there, so I might get you to start from the slide when she was diving into.
Oh, sorry, I do beg your pardon. With this particular young girl, she was 12 years old at the time. She was on a school swimming lesson. So they were taken to a local swimming pool. One of the instructors at the pool instructed her to dive in. Unfortunately, the water was not deep enough for her height or her weight, and she hit her head on the bottom, and she's now total quadriplegic, requiring complete care. She won one of the biggest cases in Melbourne. I think it's about 20 million in the end. My role was a very small role. I was simply assessing her future needs, what kinds of care she needed, because she needed support with every aspect of her function, bowels, bladder, movement. She could only move her head. It's just tragic, absolutely tragic. So bringing it all together, I'm sure you've all heard this Swiss cheese phenomenon that we talk about in medicine. It's rarely one person, apart from those 2 nurses that were involved in the criminal case. Usually my reports cover all aspects. So they cover things like staffing levels, the acuity of the patients on the ward. Obviously, a lot of the time I don't know what that was, but I can allude to it that if that were a problem, then that's management who needs to address that. It's usually a cascade of events between all of those things that you see on the screen there. So it's never that we're just going after one person. That's not the point of a nursing expert report. We absolutely love investigating and finding all aspects of the case. And when I say we, I have 2 other colleagues who work independently as well. And while we all have general nurse training, they have different levels of expertise to myself. And if ever I get a case that's specific to one of them, I will contact the lawyer and ask them if they're happy for me to hand over to them. So the kinds of opinions I provide, it's for the plaintiff or the defendant. Most of the cases settle at mediation. There's very few that I think I've only ever been involved in one conclave and gone to court a couple of times. The majority will settle at mediation, which I'm sure you all aspire to. So what I find helpful is from an initial contact, I will send a copy of my CV, schedule of fees, so that you can have a look and see if it kind of matches what you're looking for. Usually I will be sent the brief of documents electronically these days, which is fabulous. Saves a lot of storage time, storage capacity, I can assure you. And from those documents, I'll then be able to tell if the case is suitable for me, if I can support their case. If I can't support your case, I will contact you and let you know, because it's not in your interest for me to write a report and charge you for it and then find that's not helpful at all. So once we've agreed that the case is within my skill set, I'm happy to proceed. You're happy with my CV and schedule of fees, then I'll send you a quote, and then we'll agree for a teleconference when I've had time to read through the brief, just so that we're both on the same page and any questions can be asked, and then I proceed with the report. Obviously, urgent reports take priority, but generally it's around 4 to 6 weeks timeline. So this is the kind of thing I'm talking about. There's lots of things that as a nurse we need to look at. We need to look at the documents, which are often thousands of pages long. We need to look at all the different records. We need to be able to try and decipher handwriting and go through all the policies and then bring it all together and write a report. I don't know how many times I've been asked, oh, look, you know, we only need a page. It doesn't need to be, you know, War and Peace. However, one page just won't do it. It really will not help you in court if I don't explain, and my duty to the court is to explain how I came across my responses, where I found my information, and references that I back it up with. So the kinds of helpful question styles, and I'll go into this a little bit more in a minute when I show you an example of a question, why I think the simpler the better. As you can see there on the screen, it's really just asking for my opinion as to whether there was a departure from competent professional practice at the time, and determine any departures that occurred. One lawyer did send me a very difficult question. This was an example. I won't read through it because it's very, very lengthy and convoluted, and you really had to highlight which parts were important. The main thing is that kind of thing, you know, we had a teleconference Monday. Thursday, I received the letter of instruction. It was the Easter long weekend, and they wanted it by Tuesday, sorry. Well, that was extremely difficult. I did get it done, but it was all Easter weekend. Each of those questions in that particular request had 20 questions. Each one had A, B, C, D, and then they all had parts 1, 2, and 3 after that. There was 42 questions in all. It was one of the longest reports I have ever written in such a short period of time. They're not usually that long. And from my experience, the judges and the courts don't want a massive report like that. It's too lengthy, but it had to be to answer everything. So that's just sort of reiterating what kind of thing, how we go through obtaining a report. You call me, email me, I send you my schedule of fees and CV, we have a teleconference, and then I write the report. But as I said, if I don't think I can support your claim, I will say so. Anyone got any questions at all?
Anyone is welcome to unmute and just jump in if they have any questions. I know I have a question actually, if no one has one for the moment. I might even start, but I noticed the part where you were speaking about sort of those cases where you kind of reference inexperienced staff and the issues that they have caused, I guess, when they don't know the patient, or they're sort of not experienced in the sort of issues that are arising. Are those sort of issues that have you've seen an increase in frequency, or those sort of cases? Have you seen more of those during the pandemic, where obviously nurses are being overworked, people are sort of tired, family members and friends can't really come in as much, so they actually don't have that reference point of people who know them, sort of to say, oh, this is a bit weird, they're not normally acting like this. Has there been a noticeable increase, or not really?
Not really, but I guess too, most cases, you have your limitations, your time limitations, and quite often, unfortunately, we only get contacted when we're getting close to those statute of limitations. So, we're probably only going to just start moving into the era of the pandemic over the last couple of years. Up until now, no, that hasn't been, but certainly that would come into play. Absolutely.
Time will tell, I suppose.
Yeah. We'll just have to wait and see.
Yeah. Okay. Did anyone else have any questions? I might leave it open for a little bit longer. This sometimes happens when the presentation is so comprehensive that no one sort of has any questions, because they'll answer in the presentation. I think I might have just got a message. Matthew Bridger just messaged, and he said, thank you for the great presentation. And he asked, are you finding more mistakes being made because nurses and midwives are overworked, hospital understaffed? So kind of similar to the one we were just chatting about then. But I guess more specifically, are there more mistakes being made because of all this?
It's very hard to tell, because you don't know what the staffing levels are unless that becomes part of the questions. And occasionally I've been given rosters so that I can analyse, but I don't know the acuity of every patient on the ward. Certainly if I've got an overview, which often comes as a statement from a nurse, from someone working on the ward, I might do a telehealth call with a teleconference with one of those nurses to get their opinion. They'll provide a statement to the lawyer to explain that, it was just so impossible to carry out their duties. And again, that comes back to a management issue. So it is something we cover, but it's not really delved into a great deal. It's something I cover as if there was a shortage of staff, if there was the number and skill set of the staff as opposed to the acuity of the patients were not in sync, then again, that's a management issue. But nurses have to report that to management. And they need to document, even if they diarise in their own diary, it was impossible today, 2 staff off, there were too many patients for us to deal with, that sort of thing. At least there's some record. Unfortunately, we don't often find any kind of record of that sort of thing.
Okay, thank you for that question. Does anyone have any more questions before we wrap up? You're welcome to either message me like Matthew did, or just pop your microphone on and just go for it, basically. I've got one more question from in the chat. So Deema's asked, I'm wondering whether the standard of care has reduced or deteriorated over time in the medical sphere, e.g. compared between pre-COVID to post-COVID, or is it assessed case by case?
It really is assessed case by case. And I think you might have heard me mentioning to Joe that we're really only coming up to the era, as far as cases are concerned, we're only coming up to the era where we were in the pandemic. So I guess that would be something we'll see with time, and certainly something that would need to be taken into consideration. I mean, the load on staff has been horrific during this pandemic. It really has been. I mean, I've been working as a vaccination nurse just to help out at one of the respiratory clinics, and it's just full on, even from that aspect of care, and that's not in the hospital system.
Totally. I've got another question here actually from Jeanette, and she's asking, are you able to easily access hospital records such as clinical incident investigations and RAC reports to support your case assessment?
I'm not permitted normally to look at RSAs because they are something that are supposed to be, kept private for the internal hospital system to assess their own when things have gone wrong. I will always ask for an incident report. Generally, they are provided because they do become part of the clinical record. But if it's not there and an incident has occurred, I will ask for it. I can write a report without it and state, because sometimes it's time sensitive and they need the report. They might try and get it later, but I'll document in my report that there ought to have been an incident report, but none were found in the records. But generally speaking, sometimes the lawyers will send me the RSA, but I'm not supposed to use them to support my claim.
Jeanette said thank you for that answer. So that's great. I might try and get one more question in if someone's got one. And thank you for sending these in. Feel free to keep messaging them. Give it a couple more seconds, then I might wrap it up. Okay, we might end it there. If someone does have a question after, maybe that it comes up. Oh, sorry, hold on, I've got one more. Just in the nick of time. So Jeanette's also asked, do you think there will be an escalation in cases in aged care post-Royal Commission report?
Oh gosh, I am expecting so. I think we all are expecting so. I would just love to see some action taken in regard to the Aged Care Royal Commission, because it just seems like this is a repeat of what we've had before. We've had these kinds of things, occur before, and lots of recommendations, but not acted upon. And it's been quite some time now. It's been a couple of years since the Royal Commission wrapped up, and admittedly, yes, we've gone through a pandemic since then, but things haven't changed, unfortunately, in aged care.
Sorry, I was going to say, I suppose that's another probably yes, but we'll have to wait and see.
Yeah, we'll have to wait and see. Yeah.
And I can see you've just changed the slide as well.
Yeah.
Is that you when you were starting?
That's me when I first trained, back in the dark ages in 1975.
That outfit is unreal. A bit different to now.
We actually loved our uniform back then. We were very proud to wear it. Do you still have that one? I don't still have it now, no, sadly. During my training, we had the typical sort of striped dress with a white apron over the top and the stiff belt that went around the waist, and little hat. Would be good for a Halloween outfit now, but okay. I might even, is there something you want to add about this last page as well? I sort of realized just saying, that an expert in anything, as I've said, was once a beginner, and I was certainly a beginner back in 1975, and just continued my education along the way and it's so important because I've actually just completed a refresher course through the College of Nursing, not because I really needed to, but there were a couple of small things that has changed over the last few years. And of course, doing the vaccinations meant I had to complete a lot of online training for COVID vaccinations. We have to train for each individual vaccination, and there's quite a few now. And now, of course, we're doing pediatric as well. And so all of those things have kept me up to date, apart from all the other things that I've encountered along the way.
It's never too late to continue learning.
Absolutely not. Absolutely not.
Okay. Is that your contact there as well?
Yeah, that's my contact details.
These slides will go out, of course, so everyone will get a copy of these as well as the recording.
Yep.
And so everyone who obviously attended, and I can send those out to you guys, and you've got her contact here as well. All right. I might make myself host again.
Okay. Well, thank you everyone for your attendance. It's greatly appreciated.
I've had some just messages here. You might be able to see a few people sending their thank yous. Thanks everyone for coming. And again, Eunice, absolutely, you can see there's a complete wealth of knowledge you've got, and it's really insightful to listen to you speak. Especially, I mean, I found super interesting that you're involved in those, I guess, those high profile criminal cases as well, which is just obviously shows how much work you've done in the field. So thank you so much for hosting, and we'll have you on again sometime soon, maybe on a different topic.
Thank you, Joe. Thanks for the invitation. Appreciate it.
No drama. I'm going to stop the recording there.